So patient is a 30-year-old male who sustained a gunshot wound 1 month ago. He is Asia Scale B and neurological level of injury is at T1. He had a fracture of his right humerus in which he had to get a open reduction internal fixation surgery. Patient does live with family. He has 5 steps to enter his home. He needs more education on pressure relief, and his goals are to get home as soon as possible to be more independent.
So the next part, you're going to list 3 major muscle innervations at this level and 2 available possible movements. So 3 muscle innervations and 2 possible movements, and then come back.
So because this patient is a T1
Does
level.
Does it have to be at this level specifically or any level above?
At this level.
Okay, so because this patient is a T1 neurological level of injury, he has internal and external intercostal innervation. He has paraspinal innervation and intrinsic muscles of the hand, such as the lumbricals, which this allows for improved grip strength. His upper extremities are fully intact, so he has all elbow motion, shoulder motion. Some upper trunk stability is intact to help with his posture and balance, and he does have improved breathing and endurance because of the intercostal innervation.
2 short-term goals. So state 2 short-term goals and then come back.
So the first short-term goal for this patient is in 1 week, patient will be min A with bilateral rolling to promote pressure relief to prevent pressure sores. Short-term goal number 2 is in 1 week, patient will be min A with supine to long sit to promote bed mobility for ease of dressing.
Okay, the next thing you're gonna do, you're gonna start the patient supine, so you're gonna go supine to sideline via rolling, whichever direction you wanna go to prone on elbows. Okay, so supine, rolling to sideline to prone on elbows. The patient is mod assist, so just make sure to provide the level of assist. So before you start this, make sure to wash your hands, introduce, get consent, all of that, and so the patient should be left on prone on elbows after this. Okay, go ahead.
So hi Beata, I'm Sam. I'm the student physical therapist that's going to be working with you today. Before we get started, could we just confirm your name and date of birth?
Yes, Beth, I need that 12/22/85.
Great. So Beata, what I want to start with is just to do some techniques to help you move in bed better. Does that sound okay to you?
For sure.
Okay. So this first thing I want to show you is how to roll onto your side and then onto your stomach. So what I want you to do is just put your arms out straight in front of you. And what we're going to do is we're going to start in this motion to kind of build up momentum. And I want you to quickly roll onto your side like that, okay? But I want you to make sure to also, when you're rolling this way, turn your head with you.
Okay.
Good. Good. So the next thing we're going to do here is I want you to try and reach out that way to get onto your stomach. Good. Okay, and let's bring your elbows underneath you. Good. Is that still doing okay?
Yes.
Great. How's everything?
section, you're gonna perform one intervention with the patient on prone on elbows and provide your rationale and then perform it with the patient. So an intervention with the patient in prone on elbows. Provide your rationale and perform it.
Okay. So the intervention I'm going to do with Beata is, Beata, what I'm gonna have you do is just to help promote our mobility a little bit. I want you to now use your elbows to turn toward me and kind of turn your body into like a C motion, because this is gonna help just strengthen your arms and get that muscular endurance ready for you to be able to do this on your own in the future. Okay? So what I want you to do is let's use your elbows and shift them this way. Good. Good, we're gonna keep going. Okay? And now let's go back. Good. Good. Now let's go the other way as well. This is gonna help with your endurance. Okay. And now let's go back to where we started. Great. And we'll go one more time. Come toward me. You still doing okay? Great. And you want to make sure you really dig your elbows into that mat to help with your movement. And let's go back. Great. Okay, good.
Okay. Okay. The next thing you're gonna do is you're gonna assist the patient from prone on elbows to long sitting. So they're in prone on elbows, assist them, their mod assist to get into long sitting.
Okay, so Beata, what we're gonna do now.
No. Shit.
What? Is she okay? Yeah. Alright, so Beata, we're gonna build off of what we were just doing, and we're gonna do that same motion toward me. And this time I'm gonna help you bend your legs now, and we're gonna get you to end up being on your back, okay?
Okay.
Okay, so first let's just do that same crawling toward me. Keep coming, keep coming. Okay, pause here. From this moment, I want you to try and flex your leg, bring your leg towards you. Good, now let's do the other one. Great. Okay, keep going. Okay, and now what we're gonna do is roll yourself back over onto your butt. Good. Use that arm. Push up. Great. Still doing okay?
Mhm.
Great. Also, while we're in this sitting position, I'm gonna go ahead and put this on you for safety. Is that okay with you? Hey, what the heck? Why is this like? How's that feel? Feels okay?
Okay, so the next part, you're going to, so the patient is not assist for this transfer from prone to long sitting. So perform an intervention to progress this patient and any part of this intervention from prone to long sitting. Okay, and provide your rationale and perform it with the patient. So an intervention to address independence in prone to long sitting. Rationale and perform it.
Okay. So Beata, what we're gonna do next is, so this, I want you to be able to eventually do this on your own. So we're really gonna try and work on that core strength and your arm strength to be able to pull yourself up. Because before I was kind of helping you up, but I want you to really be able to do it on your own. So what I want to try is just doing it in reverse. So what I want you to do now is, let's turn back over toward me, onto your side, good. Okay, and I want you to practice again, crawling toward me. And now what I want you to do is hook this arm around, and I want you to really try and pull yourself up with this hook, okay? And pushing up here. Good. Does that feel a little bit easier?
A little bit, yeah.
Okay. So let's try that again. Let's just keep going. We'll go back down. Okay. Do that crawl. We'll make sure to hook and really push through on your elbow to give yourself some leverage. Good?
Mhm.
Okay. And that's going to really help with just your mobility overall. It's going to help with you being able to do ADLs, get dressed. Like, once you get that core strength and the upper extremity strength to do things yourself, it's just going to be easier overall for you. Do you have any questions for me?
No.
Great.
patient's range of motion and her spasticity on the exam, state one concern you would have and how you would address it. You do not have to perform anything, so you just are stating. So state one concern you would have about your patient's range of motion and spasticity exam and how you would address it.
So the patient did have, she did have some spasticity.
Yes.
Would you mind blowing up the case again?
So because this patient did have +1 spasticity present in her ankle plantar flexors, my main concern of this is when the patient does go home and is using a wheelchair, we want to make sure that her feet are being able to sit how they're supposed to in the wheelchair, and this will also, when we want that dorsiflexion range of motion, this will also promote like independence for the patient with once the patient starts doing some walking innervations, to get her shoes on and off, just to do things with independence in general. So to address this, I would probably introduce some type of passive range of motion stretching to the patient for to increase her dorsiflexion and decrease that spasticity in the plantar flexors. So what I could do is give the patient probably give the patient a band, and this is something she can also do at home to wrap around her foot and pull her toes toward her to improve that range of motion and just passively stretch the plantar flexors.
Okay. The next thing you're going to do is you're going to instruct the patient on an inner thigh stretch. So you're going to instruct her on how to do it and have her perform it. Him or her. Inner thigh stretch.
Okay. So Bata, this is a stretch for your inner thigh muscles. This is just going to help with any tone and tightness you're having. So what we can do is I want you to try and give yourself as much support on that arm, okay? And I want you to lift this arm, and what you're gonna do is pull this knee outward. Good. Good. And what you can do this at home as well, is you can just slowly like press down into this knee right here. Do you feel a stretch in the middle there? Good.
Yeah.
So you can hold this for about 15 to 30 seconds. Any type of stretching you're doing, you want to hold it for about 30 seconds. And you can do it probably 3 to 4 times a day just to help improve that range of motion overall. And then we can also switch and do the other leg as well. So let's move your knee, we'll straighten that leg back out. Okay. You still feel that same stretch there at all?
For sure.
well, you may not necessarily feel it completely due to your injury, but this is good just to hold down and do on a daily basis. It'll help you also sitting in your wheelchair and just doing activities such as dressing. Okay, and then let's push your leg back in. Good.
Dr. Yoda? Yeah, I had a question. So for this, are we teaching the patient, are we doing it to the patient, or are we teaching them to self-do it?
The patient's supposed to do it themselves. You're teaching them on how they should do it themselves.
Okay, thank you.
Okay. Okay. So when you did the adductor stretch, you noted that there was a hard, bony end feel. It was painful, there was edema, and there was heat. What would be your differential diagnosis for this, and what would be your management with your range of motion program? So differential diagnosis, and what would be your management with your range of motion? So you're just stating this. You don't have to perform anything. So differential diagnosis and the management with your range of motion program.
So because of the hard bony end feel that was felt and there was some
Dr. Yoda, do you mind repeating that?
Okay, so you were doing an adductor stretch with this patient, and you noted a hard, bony end feel. It was painful, there was edema, and there's heat at that joint, at the hip joint. So what would be your differential diagnosis, and how would you modify or manage your range of motion program?
So because of the heat present and the hard bony end feel, I would possibly suspect that this could be the heterotrophic ossification, meaning that there are some calcium deposits developing within the muscle itself. This is pretty dangerous because it could stiffen up the muscle. To modify my range of motion stretching performance with this patient, I would probably not fully go into her end range of motion. I would just passively take her to just before I felt that hard bony end feel before, and see if that changes the pain or changes anything with the patient in general, any symptoms she may be having. I also at this point would monitor her vitals and then immediately follow up with the physician about my findings and what I'm possibly suspecting, and see what they say about that as well.
going to do is assist the patient from long sitting to sitting edge of bed to chair. Okay, so patient is mod assist. So long sitting to sitting at edge of bed to the chair. So they should be in their chair at the end of this portion.
Okay, Bata, so what I want to do next is we're actually going to get you into the chair. Does that sound good?
Mhm.
Okay, so what I want to do, just to instruct you a little bit, is we're just going to start by segmentally moving your legs, okay? And I'm going to have you help with this as well. So you can keep this arm steady, and we're going to use this other arm we can first start by you can just hold your arms down real quick. I'll just show you. We'll just start by segmentally moving, and then we'll start with this leg, and we'll just segmentally get you to the side, okay? Okay. So I'm just gonna get behind you a little bit just to help with your balance. So what I want you to do, start with this leg, and let's slowly go. Good. Good, and now from here, let's scoot forward, so press down through those elbows and hands. Good, okay, 1 second. Okay, let's do the same thing. Good, one more. Good, okay, and let's just hold it right there. And the big thing with moving you from the bed to the chair is we really want to use your legs as a pivot point to help with your balance and just overall ease the transfer. So what I'm gonna do is, just to start, put this around your legs just to make sure we're staying in this closed position. Okay, so this is gonna just really keep your thighs together. And now what I want you to do is we're gonna press through those elbows again and those hands, and let's just scoot to right here, okay? Good. And then what we're gonna do now is on 3, we'll completely go into the chair, okay? So 1, 2, 3. Good. Does that feel okay?
Mhm.
Great. So paranoid that's gonna shut off. Keep looking at it.
So while the patient's in the chair, you're going to instruct and educate them on pressure relief. Make sure you give them feedback in this position. So pressure relief in the chair. And then your patients are done.
Okay. So Beata, this is also something very important. We want to do pressure relief probably for about every 30 minutes for at least a minute. This is really going to prevent you from getting any type of bed sores or ulcers or anything, which it could end up turning into infection, and we just want to completely avoid that and prevent it if we can at all costs. So because of your strength in your arms, I'm going to teach you a pressure relief technique to help kind of lift your butt up off the chair. So what we're going to do is you can just set your arms here. And in your wheelchair, you're going to have the arm rests, which you can do this on and push up through the arm rests. So what I want you to do is really like lock out those elbows, and you can lean a little bit forward and just push yourself up off the chair. Good. And you just want to make sure your hips are really off of that seat. Like I said, for about a minute. If you're not feeling as strong that day, or you're just feeling very fatigued, what we can also do is, as a additional technique, is you can just slowly lean forward over your feet. Yep, just keeping your arms to guide you. And it's the same thing. You can really relieve those hips from the chair. Okay, and we can go back. So like I said, for about a minute if you can, preferably every 30 minutes, most important. If you have to, set an alarm on your phone to remind you if you forget about it. Yeah, any questions with that?
Mm-mm.
Okay, great.
Okay. So the last part is the thank you to the patients. Thank you guys. The last part, you guys are going to state 2 long-term goals and then your reflection, area of strength and area of improvement. So 2 long-term goals, area of strength and area of improvement, and then you guys are done.
Okay, so long-term goal.
Sorry if this question was already asked, but where do we send our videos to you, Dr. Giulietta?
Yeah, just email me the videos.
Okay. Thank you.
Thanks.
Okay, so long-term goal number 1 is in 4 weeks, patient will be Mod I with bed-to-chair transfers to promote household ADLs. Long-term goal number 2, in 4 weeks, patient will be Mod I with static sitting balance without upper extremity support to promote trunk control for dressing. An area of reflection, I think I was really strong in just telling the patient why they're doing certain interventions, the importance of doing pressure relief, just the whys behind what we're actually doing as physical therapists. And I think something I need to work on is probably my own body positioning with the patient, like where to guard them, where to assist them more than other areas. And also, if it's possible, maybe I could demonstrate it myself. Like maybe in a real clinic situation, if we're on a way bigger mat, I could just lay next to the patient and actually perform the movement or intervention myself, and then have them watch me, and then they could do it after. Thank you. Washing out. Bye.